Good evening, everybody, and welcome to Death Creations, our virtual education series about end of life. I'm Julie Evans. I'm the Executive Director of Casa de la Luz Foundation in Tucson, Arizona. And for those of you who aren't familiar with us, our vision is to transform the end of life into the experience into the final act of living well. And one of the ways we do that, we have sort of our 3 mission points here on the screen, but one of the ways we do that is through supporting end-of-life care research. And I'm so pleased tonight to have our friends from Casa de la Luz Hospice talking about a research grant that we've been supporting for the last few years. We're looking at non-pharmacological ways to help folks who have dementia and agitation. And so I'm so excited that you're here to learn with us, and later on during our question and answer session, having an opportunity to share your experiences. Before we get started, I just want to give a heartfelt thanks to our friends at Pima Council on Aging, who is sponsoring tonight's event and making it possible for all of us to be together. And so I hope you enjoy this. And I want to now introduce David Fife, who is one of our foundation board members and the chair of our education committee. David?
Thanks so much, Julie. We're grateful to Dr. Powell and Piper Frithsen for your time with us tonight, and grateful to all of our amazing participants for taking part in this important conversation. If you have questions for our presenters, just as Megan had said earlier, please put them in the Q&A box that you will find located at the bottom of your screen. Just click on the Q&A box and then type in your questions. After the presentation, we'll get to as many questions as possible. We want to warmly welcome both Dr. Powell and Piper Frithsen. Dr. Powell is the Associate Medical Director of Casa de la Luz. She has been an advocate of research and advancement in the areas of palliative care and hospice. Dr. Powell is the founder and current chair of the Casa de la Luz Agitation Committee that we will hear more about tonight. Piper Frithsen serves as the Casa de la Luz administrator. She has been a registered nurse for over 25 years and brings a wealth of bedside and leadership experience to the field. Piper's commitment to the welfare of patients and nursing excellence shows in all that she does in her leadership role at Casa de la Luz. We're also grateful that Harbhajan Khalsa from Pima Council on Aging is also with us to take part in this important conversation. And Dr. Powell and Piper, thank you for taking this time with us this evening and sharing your valuable work. We're all yours.
Hi, everyone. Welcome. Thank you for joining us this evening. My name is Piper Frithsen, and this is Dr. Becky Powell, and we're here to talk to you today about dementia. The struggle is real. So our objectives is we want to outline the top behavioral difficulties for patients with agitation and dementia, discuss limitations of pharmacological management, examine ways to individualize care for the agitated patient or loved one, discuss integrative and alternative non-pharmacological therapies, which is my favorite part of this talk, review preliminary statistics, and discussion regarding the trends and future directions.
So the question is, why are we talking about this? I'm Dr. Powell. I've been with Casa de la Luz for 5 years now, and about 4 years ago, I ran into a patient with severe agitated behavior and dementia that I just couldn't control with medications. And so Casa decided that we as an organization needed to advance the field of medicine as much as we could and start looking for non-traditional ways to manage patients with dementia. So we did a little research. That's the beginning of all great breakthroughs in science as it is. 80% of patients with dementia have unwanted behaviors of some sort during their disease progression. I say unwanted behaviors as opposed to agitation because unwanted behaviors can be anything. It can be apathy, it can be withdrawal, it can be wandering. it can be a lot. So what does the agitated or behavioral patient look like? The most common ones we see, you see on the screen in front of you. You can bite, hit, kick, you can fidget repeatedly, you can have ups and downs in terms of mentation and confusion that comes and goes. You can be apathetic and withdraw from your environment, have hallucinations, both visual and audio. You become delusional, suspicious. A lot of people have day-night reversal. You repeat things over and over again. You wander around your house, you wander outside your house, you walk into the street. Wandering in and of itself is not necessarily bad until that person walks out the door into a busy highway. So a lot of these can become increasingly unsafe. You can get to where you're too suspicious to take your medications. You're too aggressive for caregivers to want to help you. You're wandering into unsafe environments. You're so repetitive that people just can't be around you. Have you ever walked down the hallway of a hospital and heard someone crying out, "Help me, help me, help me, help me," and wondering why no one goes into the room to help them? Well, it's because crying out, "Help me, help me, help me, help me, help me, help me, help me," is really common in dementia. And you walk into the room and you say, "What do you need help with?" And they'll say, "Nothing, I'm fine." You walk out and they start saying, "Help me, help me, help me, help me." So what do? How do you help them? How do you help them when they don't know how to help themselves? The first thing we look into are patient factors that affect their behaviors. They're characterized into different groups. Some of them, there's nothing we can do about it. I can't change your personality. I can't change any events that may have happened in your life. I can't change who you are as a person. I can't change if you've had a stroke or not, if you've had brain trauma of some sort. I can't change the severity of your dementia itself. But what can we change? So some of them are easy. Some of them are the patient has pain and they can't verbalize that. So just something as simple as Tylenol may help. Sometimes there's an acute medical issue, maybe a urinary tract infection. It could be as simple as antibiotics. It also can be as simple as they're too hot or they're too cold, but they don't know how to express that. So if you look for a need that's unmet in the patient, if you look for something that's modifiable, when you look at them as a person, sometimes you can affect that. That's not really what this talk is about, though. Those are the easier ones that your physician or provider can usually handle. We're looking at the ones that are a little bit more difficult. Partially modifiable behaviors land in that field. Neurotransmitter changes specifically, let's talk about that for a second. This is where we talk about your medications, your antidepressants, your behavioral medications to begin with. Partially modifiable. Some of them work, but sometimes they don't. So then we have to go to environmental factors. So again, some things are not changeable. I can't fix the fact that their loved one just died. I can't fix the fact of where they physically live and the structure around how things are set up. We kind of can fix and intervene with family dynamics with great social work programs and whatnot in the community. We can help sometimes with caregiver quantity, especially with caregiver quality sometimes, and simply with education. We can, under the modifiable line, give more education about the condition. We can help alleviate caregiver stress. We can figure out if we need to give them more to do or put them in a more isolated environment. We can put them on a structure so they know what to expect. All in all, we can educate and help relieve some of that. But again, what if this doesn't work? What if they have a great caregiving situation? What if they have a great routine? What do you do next? What's the next step? So education is a place to start. I'd like to focus on the bottom line because we've already talked a little bit about the first two. Poor communication is really what I see more than anything else in terms of easily influenceable factors to agitation. If you give somebody too complicated instructions, they can't follow it, they get frustrated. If you talk too fast, they can't follow it, they get frustrated. If you tell them if you give them too many statements at once, they get frustrated. It's really easy as caregivers or as medical providers, I'm guilty of this myself, of trying to fill the silence. when someone's trying to respond to you and they have the delayed responses that's typical of someone with dementia. And instead of after a question, you stop and wait and be patient. And instead you fill the silence and keep talking and talk quickly and don't give that patient a chance to respond. What's going to happen is they get overwhelmed. Just like you hear me stop and be patient and wait, and you wonder, okay, keep talking. Versus if I get going really fast, that I have a tendency to do, and you go, slow down a second, I can't understand you, you're talking way too fast, and I could do this really fast if I wanted to, but I'll save you that hardship. So being careful about communication is important. But when all else fails, we turn to medications as the typical first-line approach. There's 5 main categories we use. Antidepressants probably have the most literature behind them. Trazodone has some literature, Celexa has some literature. There are some medications that have some evidence that they work, but the typical antidepressant takes 4 to 6 months to be fully effective. If someone's wandering into the street, if they're biting and hitting and kicking, you don't have 4 to 6 months to wait, especially with a severe disease process like dementia. And every day that passes, they get worse and worse and worse, little by little. 6 months is a very long time. Antipsychotics are used all of the time. Haldol, Risperdal, olanzapine, they're used quite frequently. It's great for acute psychosis, for the hallucinations that we see, even for delusions. Unfortunately, there's a black box warning, not unfortunately for the warning, but unfortunately for the fact it does increase death. 3.5% increase in death. That is a huge increase in death. There's an increased risk of stroke, and they can be downright dangerous. Plus, I don't have this on the slide, but more and more literature coming out says that it does not help. There's less and less efficacy long-term. They did a recent study in the hospital where they gave patients antipsychotics who were acutely agitated in the hospital and measured the severity of their agitation before and after the antipsychotics. Their agitation was absolutely not better and potentially even worse if they received an antipsychotic medication than the patients who received a placebo. So now we talk anti-anxiety medication. It's used commonly for sleep and anxiety. I love that third part there, can worsen memory. The last thing that we want to do with our patients that we're trying to preserve their quality of life is to worsen their memory. It increases the risk of dementia development in general for older patients. And patients who have dementia, it can expedite their dementia process. We still use them sometimes because oftentimes we don't have much of a choice. It does increase fall risk because they can get unsteady, but if it's the only way to keep them in bed, sometimes families are desperate. Sometimes providers are desperate. Sometimes we do whatever we have to do to try to improve the safety profile. Mood stabilizers are used commonly. Sometimes you see the most common is probably Depakote or valproic acid, which is a preparation of valproate. The Cochrane review found that it was pretty much useless. In fact, it had significant risks, including falls. There are some others that are used. Sometimes you'll see Abilify used. Sometimes you'll see lithium on a rare occasion. None of them show any major significant benefit in the management of behavioral and psychological problems in dementia. Sleep aids probably have the second most literature outside of antidepressants. Melatonin has a growing body of work that says it may reduce agitation long-term because it improves day-night reversal, helps you sleep at night and be awake during the day, which is great, but there's downfalls of that too. And really, there's not great data. It's very limited. So the question is, what do we typically do? I apologize, the screen's a little difficult to read, but we pulled common medications that are used, some of the names I've previously said, and I pulled the cost for 30 tablets. So this is simply 30 tablets across the board. You can see that the numbers really add up. So a typical regimen would be citalopram, otherwise known as Celexa, once a day, Risperdal, which is an antipsychotic, twice a day, Depakote, which is a mood stabilizer, 3 times per day. Now, I didn't give you an anti-anxiety medication, and I didn't give you a sleep aid. So this is just using 3 out of the 5 categories. You're still talking about almost $400 per month in retail cost with almost no efficacy. But beyond the monetary cost, what's the intrinsic cost? Is it falls? Is it injury? Is it less ability to interact? Medications are not the answer. So we went a step further and said, what do we do?
So this is the fun part. So when medications fail, so further research is needed. So as Dr. Powell had shared with you, when she started this journey of research, there wasn't a lot out there. There wasn't a lot that we had a toolkit as providers and as clinicians that could pull and help a family on how to help with the agitated behaviors at home. A majority of our patients live with their family members. So the caregivers are untrained clinical individuals caring for their loved ones. So there needs to be more research, and that's why we started this, is how can we help our caregivers and our families. So the need for the agitation program was established, and like I had said, there were no established programs. Tons of research, you couldn't really find it. You could find little clippets here and there, but nothing that was a toolkit or a program. What we can incorporate for families experiencing, we want to be able to decrease the harmful or potential harmful medications, but also look for things that engage the patient and the caregivers and give some relief. That is the creation of the Agitation Consult Team, ACT, which I have to giggle. I think there was 3 or 4 meetings before we came up with the name. So what this is it is an interdisciplinary team that Casa established, that is a social worker, a chaplain, volunteers, a nurse practitioner, a registered nurse or a few, a licensed LNA, which is like a CNA or caregiver, and a music therapist, because all of those are, and a physician. I don't see physician up there. She's the leader. But it's a team that comes together to talk through what is the information that we're gathering from the family or the caregiver, and what recommendations have worked or haven't worked, and so we need to reevaluate. So they continue to meet weekly to talk about patients that are brought forward from families or from the teams that we serve, and that's where we started to build a toolkit. So the first thing we need to do is identify the needs of the agitated person. So every person is very different. They have a very different story. They have a different situation. So the first thing that we want to do is, what is their story? Asking family, friends, caregivers, which I tell a lot of stories and I apologize. One of the things we learned in one of our first agitation cases, we learned much more from the owner of the care home she lived in than the family, that there had been traumatic injuries when she was a younger woman, that actually fed into some of the behaviors that we saw in her. And it completely changed how we went to serve her and work on her agitation. So what is their story? Helpful information to have and learn. Are there significant health issues? Are they sensitive to cold? Some of the things we see with showering and biting is because they're really cold and they're already a cold-natured individual. Again, family history. Is there a resemblance to a caregiver? We've walked into homes and we've reminded them, because we all sometimes look alike, of a daughter or of a past husband, or we can remind them of a great person, but also maybe somebody that caused trauma in their life. So being in tune and using that ability and intuitiveness to see if it's one caregiver that always comes into the room and there fuels agitated behaviors, we have to start looking at that. Childhood trauma, that feeds a lot into our modesty program, and just understanding how they grew up. We had one individual who every time you shut the door, she would scream. So here we were offering privacy, and she would scream and scream and scream and scream. Well, we finally learned that she used to get locked in the closet. So she was scared of closed doors and she was scared of the dark. So being able to still provide that modesty, but managing the cause of the agitation helped her and helped the family. meaningful life events, career paths. Understanding where they found value in themselves is huge. I think a lot of times we forget that there's still this beautiful person with a soul and meaning inside. And so how did they find value in themselves? So some of the things we'll talk about is reconnecting back to those career paths or life things that they did. Preferences. Just because they become agitated or have dementia doesn't mean that they still don't prefer art or music or books. We just may have to change the way that they're presented or re-inject them back into the light or into their life. Or chickens, and we'll talk about the chickens here in a bit. So one of my favorite things that we get to do is animal assisted therapy. So we've heard about it on TV and in studies, but animal therapy is huge. There's benefits. It improves mood and social interactions, not just with the agitated loved one, but also the family. It improves nutrition, it provides calming, and it benefits the family. There's many different types, which I giggle. So that is our little therapy pig that was in training that came into the office. And I can't remember her name, but she's cute as a button. And then one of our therapy dogs. So dogs, cats, birds, fish, whether they're alive or a little electronic thing in a bowl, it works. Pigs, horses, and sometimes even not the animal that you've brought into the relationship. So we have an inpatient unit, and we had a patient that came to us with a sudden decrease in life expectancy, and she was the monarch of the family. We probably had 30 family members from 2 all the way to 60, all within our inpatient unit. And they were very upset and struggling with all of a sudden the monarch of their family was facing death. And we could not connect and get to that point of having the conversation about grief. And it was the 2-year-old. So our inpatient unit is right on the Riverwalk. The 2-year-old came running into the unit saying, because the bats fly, I personally don't find much therapy in bats, but it's a beautiful thing it does when the bats take flight. So she came running into the unit and she said, look, the bats are flying free like grandma. And that moment gave us the ability to start the conversation differently. We also have equestrian therapy at our inpatient unit, and my stepfather died at our inpatient unit. And the actual therapy horses helped us connect family-wise and connect my stepsister with what was happening. You pet the horse, and the therapist helped to calm your breathing and your heart rate to match the horses. And the whole time they're getting a pet and they're eating the grass. They absolutely love it. So music therapy. So music therapy, there's 2 things. True music therapy can make the difference between a withdrawal and awareness, being isolated or interaction, between chronic pain and comfort, between demoralization and dignity. So playing music isn't necessarily music therapy. So we had a music therapist, we had a patient on service who, we had maxed out his medications and he continued to be in pain. We could not find comfort or quality for this individual. So we sent in our music therapist, and I'll probably cry and you'll just have to ignore me. So she sat down and she starts with music. So tell me a song that you like. And he said, well, Georgia on My Mind. Great. So she's like, I'm going to play Georgia on My Mind. No. He said, I can't hear that song. I can't hear that song. So she started naming other artists and songs from that genre and that time frame. And he said, he looked at her and he goes, no, let's do it. Let's do this. And so she starts singing and playing guitar, and she starts singing Georgia's on My Mind. And he starts crying. So she continues to play, and by the end of it, he's sobbing. So then here comes the therapy component. Tell me what you're feeling. What does this song invoke? And through that therapy moment, The first time he's ever confessed since childhood is he was beaten to that song. So we were able to start with therapy and dig into that trauma that was creating some of these behaviors. And we were able to actually discharge him from hospice with no medications, and he's not returned to service. So sometimes using different therapies to get to the heart of what's creating that behavior allows a different conversation. Volunteers. And this is why we are so excited to also partner with PCOA on this conversation, because we have volunteers within our teams. But if you don't have a loved one on hospice or in palliative care, how do you get a hold of volunteers? So we're thankful for PCOA to be involved for their community resources. Volunteers are lovely. Sometimes they are the best at being quietly present. Just sitting with a patient is huge, or a loved one. Caregiver relief. We cannot stress enough how important it is for caregivers to have relief, have an outlet for themselves, to take care of themselves. Because as they get tired and anxious, that feeds into the behaviors that they're seeing. So if you have an exhausted, frustrated caregiver, their loved one is going to feel that, and their dementia or their agitated behaviors are going to increase because they take in the feelings of others. Some things are important here. Consistency. As we know, with patients with dementia or loved ones with dementia, consistency and routines are key. So it needs to be the same person, the same day of the week, and the same time of day. Sometimes decreasing some of the agitation and unwanted behaviors truly is just starting a routine and being consistent and following that routine. So this is, so how did we build our toolkit? So we started looking at the behaviors that were coming to us. Lots of issues and concerns with showering. My loved one doesn't want to be showered. My loved one bites, pinches, kicks during shower, or screams. Boredom. When you're trying to cook dinner, we started to see some things about, that's when the behaviors came in. So we want to share some of our things with you. So I'm going to unshare my slide. And again, as you've seen from earlier, sometimes my ability with IT is not always here.
No, minimize your.
If I minimize up here, you want me to minimize here?
Nope. I want you to minimize that. And then unshare screen.
All right.
So, yep.
Okay. Sorry about that. Okay, so hopefully we will pop into the big screen here shortly. But we want to show you a little bit about what we're talking about. So the shower poncho, this was one of our easiest inventions. What we found is that showering is cold and it takes away all of their modesty. So all of a sudden we've pulled them out of their routine. And as nursing, we like to shower people in the morning. A lot of patients like to shower at night. So here, not only are we changing their routine, so again, go to their routines. If they were a night shower, shower them in the night. But a poncho, the cheapest towel you can purchase because they get heavy. And you just slip it over. Then you can take off their clothing underneath so it provides modesty and warmth. You can scrub them up underneath that poncho, rinse them off, and then you can slip a dry towel over and pull the wet towel off, and you've maintained modesty and warmth through the whole shower. Now, we did learn that sometimes they still wanted to kick and hit or bite. So we came up, and I don't know if we have one available, but a shower kit. Sometimes playing their favorite music and singing with them. Sometimes giving them a sucker to put in their mouth or bubbles to blow is important because it gives them something to distract during a task that they may not enjoy.
I just like to play with the toys.
She does like to play with the toys. So boredom becomes a lot of the foundation for some of the agitated behaviors. So pat mats. This is actually quite fun, and there's actually two uses to this pat mat. How many have heard, and we can't see hands, about weighted blankets? My 16-year-old needed a weighted blanket for Christmas because it helps with her after a busy day, bringing her calmness in place. So weighted blankets. So when you fill this pat mat up with water, it becomes, I think, a 10-pound weighted blanket. It helps remind them that they can't get up without help, but it gives them something with their hands for tactile stimulation, and it keeps them from boredom.
These actually have, I don't know how well you can see it, but they have toys inside. So that when you fill it up with water, the toys float around, and then you can play with the toys, move them around, keep something to completely entertain you while it's sitting on your lap, as well as an anti-anxiety device.
So I think one of our first, this is a weighted blanket. You can actually buy them on Amazon where they're just a lap blanket versus a whole blanket, and you can make them a shawl or just around the blanket. So, and they're usually anywhere from 5 pounds. If your loved one only weighs, 80, 90 pounds, you're probably going to want a 5-pounder versus a 10-pounder, but you can get different weights. And all of these are available on like Amazon. There's tons of opportunity for these kind of tools.
So standard, if you Google it, it'll tell you 10% of your body weight. We have found that's pretty heavy. And although it's nice because it keeps people seated, we also don't want it to fall off their lap and then try to get up and trip over it. So something that is possible for them to move is still nice. We gear more towards the 5% rather than the 10% side, but it's still reasonable to go up to 10% of your body weight.
One of our biggest one was baby dolls, especially for our patients with agitation that may have been moms. And there's weighted baby dolls or weighted teddy bears. And even, I got to tell you, we'll sit in an agitation meeting and someone will pass a weighted doll around, and whoever gets it will sit and rock and because they're weighted in the butt. So you feel like that calming, and we all do it. Cheer bears, just something for them to hug and touch. I think, aromatherapy is huge. Just make sure they don't have any allergies and it's not overwhelming. Activity blankets. So this is where we talk about personalization. So activity blankets are great. And we actually had our educator, we had a patient who was a contractor and a builder. So what she made him, similar to this, but she made him a Home Depot apron. So he spent hours with tools and things that reminded him of his career and brought value back to him. We made a briefcase for a businessman, and he would pack and unpack his briefcase every day. We gave a bunch of papers to be corrected. We had a teacher who would have agitated behaviors. So we brought a stack of papers and a red marker and asked her if she could correct those for us. And it calmed her, again, finding value with who they were and who they still are inside.
One of my favorite stories is a lady we had at a facility who the caregivers would come in at 7 and they'd leave at 5 for night shift to come in later. And she did great during the day. She helped set the table. She made sure all the other residents were eating. She would try to refill drinks. The caregivers would keep her busy. They'd keep her involved until 5 o'clock came. And then she got worse because she said, okay, I'm done work for the day. It's 5 o'clock. Everybody's leaving. So she packed her bag and tried to leave with everybody else. So trying to keep her in the facility when she thought she needed to go home like everybody else was challenging. So it was simply for her a matter of extending her usefulness throughout the day and just not saying goodbye. She never looked at the clock. She didn't have enough cognitive ability to really gauge the day, other than she was able to tell what was going on from those around her and guess. So if the new caregivers came in and said, hi, it's nice to see you again this evening, she would want to leave. If they came in and said, hey, Mrs. So-and-so, let's go fold these towels, she would go, okay, and walk over here and fold the towels. So it's just a matter of keeping people engaged and making them feel like they're valued, whether it be doing things that they feel like are necessary, folding towels or setting the table, whether it be grading papers, or whatever it may be to bring that individual purpose and meaning.
All right, we're going to try to share our screen again, Again, you would think after a year of doing this that we would have no issues with technology, but I continue to. Okay. Oh, see, now they're on the sides like they weren't earlier. Okay. Let me see here.
Perfect.
Okay.
So we talked about cost before. The average cost for medications is close to $400 a month. The average cost of our interventions has been a little less than $20 per patient, period. Not per month, period. Now, this may underestimate the true cost to somebody outside of our organization because we did use our staff. We did have some reusable art supplies. We would buy markers and share them from one patient to the next pre-COVID. And then we had donated materials. People would give us towels that volunteers would cut into ponchos for us. There were some other things. So $20 does underestimate the true cost of what we do on a per patient. And we are funded, as Julie said earlier, through the Casa de la Luz Foundation. But this is still much more accessible to the average person, to the average family financially, than even the copays of those medications are. So, do these things work? One of the problems we had at the beginning of our agitation committee was pure buy-in. If you give a patient with dementia a baby doll and the family goes, please don't treat them like they're an infant, we didn't get buy-in. If we started blowing bubbles and family members, caregivers thought it was too juvenile, they would not do it and we couldn't get buy-in. So one of our goals was to prove that it works, to be able to give you data that shows, look, it works. We know that grading papers that are useless for the most part to outside of that individual seems silly, but does it work? So we pulled a scale, the Pittsburgh Agitation Scale. It's well established as a reasonable scale to use that's statistically valid in terms of monitoring the severity of agitation. It evaluates behaviors for unwanted symptoms in dementia in 4 categories. Verbal behavior, anywhere from not disruptive, which would be a 0, to yelling and screaming constantly. Moving around, anywhere from normal all the way through really disruptive that can't be calmed down and is not redirectable. Aggression, anywhere from normal all the way up to physical threats, all the way up to physical altercations. Or pure resisting care. No problem at all, they're easy to care for, all the way towards don't you dare change my brief, there's no way I'm going to let you without hurting somebody. On average, we didn't use just one intervention. People often needed 2. Oftentimes one of the interventions was a change in medications to address those modifiable factors from before, whether it be scheduled Tylenol or melatonin or anything else. But oftentimes they needed more than that. We would do music therapy, light therapy, weighted blankets. You can see the types of things that we use. And then personalized interventions often were one-off, so those were more difficult, like getting the briefcase for the gentleman who was a businessman and really liked his briefcase. But all in all, when we looked at the data, here's what we got. Baseline agitation scale is 4.7. The pretest is 3.2. So the reason this is different is often because if I'm the physician for these patients and a nurse comes to me and says they're really, really agitated, I'm going to do something immediately. I'm going to say, let's change the medicine. Let's do this. Let's do that. Let's do something. And then in the meantime, we're referring to the agitation committee. We're gathering information. We're trying to figure out what they need. We're doing all those other things that are not standard of care. Baseline to pretest is usually standard of care medicine. Pretest is what the patient was like at the beginning of the non-pharmacologic intervention that we used. And post-test is the improvement we got afterwards. So if you ignore the baseline to pretest change, which is fairly standard, anytime you go to the doctor or ask somebody for help, this is usually what the type of improvement you would get. The pretest to post-test is the improvement that we get just based on our interventions that are non-pharmacologic, that are thinking outside the box. Repeated measures analysis of variance, and I will not get into the statistics of this, I promise, that's not my goal of this, is very statistically significant. Our data is so impressive statistically. We actually were recently published at the Journal of Nursing and the Journal of Nursing, Hospice, and Palliative Medicine in December of last year. So we know this works. We know it works in our patients in hospice, and we know it can work for you. So we also want to extend that to the rest of the community. So the best people in our community that we know of to do that is Pima Council on Aging. And we're grateful that Pima Council on Aging can be here with us to talk about the options that they have and the resources of the community outside of hospice. So Harbhajan, let me hand this over to you, and we appreciate you being here.
Awesome. Thank you so much. Hello, everybody. Thank you for having me. My name is Harbhajan Khalsa, and I am the Program Director for Dementia Capable Southern Arizona at Pima Council on Aging. I wanted to go ahead and just give a brief overview of PCOA for those of you that may not be familiar with it. So the mission for Pima Council on Aging is to promote dignity and respect for aging and to advocate for independence in the lives of Pima County's older adults and their families. PCOA has been around since 1967, and we are a 501(c) nonprofit. We are also the designated area agency on aging for Pima County. So for those of you that may not be familiar, there are area agencies on aging in each state. So this is a nationwide network of agencies and services that are available throughout, like I said, the nation. So if you have family members that are in other states, please have them look up what their area agency on aging is for resources. We are also the service planner, coordinator, purchaser, and provider for services. We predominantly serve people who are 60 years of age and older. We target those with the greatest economic and social need. We also provide services for caregivers, for people over 60, grandparents raising grandchildren, and we do provide some services for people who are physically disabled over 18. No, thank you. So I'm not going to get into all of the services that we offer because that would take several hours and we don't have that tonight. I'm going to just do a brief overview of a few services that will pertain to the topic tonight. And then I encourage you to please give our helpline staff a call or visit our website for more information on resources. So specifically for services for caregivers, and all of this is a little bit different right now because of COVID, but we have a specific caregiver support program. We offer one-on-one caregiver consultation. Previously, it was a lot of in-person. Right now, it is over the phone unless there's an urgent reason, and we do have the ability to provide safe, socially distanced in-person meetings. We had previously offered a caregiver training. This is on pause right now, and it will be resuming very shortly. We are in the process of figuring out how to do that in the remote world. We offer throughout the county, we offer 11 or more, it kind of goes up and down, caregiver support groups. Those are all being offered through Zoom right now. We've had a kind of a mixed bag of feedback. Some people really enjoy the Zoom groups, and for some people it can be very challenging. So we are planning on having a hybrid model moving forward. So that way people who want to come in person and still have that kind of connection can do it. And then for those that are not able to leave their home, they still have the ability to do Zoom. We offer 3 types of respite care. We offer professional caregivers where we have an agency come in and provide care for the caregiver. So that way they can go to the doctor's office. They're able to take a nap. A lot of times they just want to kind of take care of their basic needs, but know that their loved one is being taken care of. We have an adult daycare program. That's where the loved one actually goes to a facility and they have different interactive activities throughout the day. So it literally is an adult daycare program. They do fantastic things. They do like arts and crafts. They'll go on field trips. They have, like was discussed earlier, musical interventions. So it's just a really fantastic program. There's also a new program that we have called Friends and Neighbors, and it's a reimbursement program where if I am the caregiver and say I want to pay my daughter to look after my mother, there's a way that we can do that. So there, you would actually come to us, we'd enroll you in services, And then you would be, so I would be like the employer. And then I would pay my daughter to look after my mother while I go to the doctor's office, while I go take care of my needs. So that's a new program that we have, which is very exciting. And then the last one we have is grandparents raising grandchildren. So this is a support program offered in collaboration with Care Family Center. So I want to give a little disclaimer before I launch into kind of my program that I'm going to talk about. So we are not currently offering these services. So you might say, why are you talking about this? We're going to offer them very soon. So we were very fortunate to have been awarded a grant through the Administration for Community Living, and we are in the planning phase. So we finished our work plan. We're doing our evaluation plan right now. We're almost done with that, and then we'll move to the budget. So our hope is, I'm looking over to my calendar, probably sometime early summer, we'll be able to offer these services. So we want to start letting people know about them. So once we do have the ability to offer them, we have clients right there ready for us. So the program is called Dementia Capable Southern Arizona. And the goal is to improve the effectiveness of dementia specialized support services in Southern Arizona for persons living with Alzheimer's disease and related dementia and their caregivers, with a special focus on those living alone and in underserved populations. So we have 4 main program initiatives. I will dive into each of these a little bit later, but the main programs are increasing outreach and awareness, increasing the identification and referral for people with Alzheimer's disease. As we know, Alzheimer's disease, oftentimes it's a disease that's diagnosed later on, and our goal is to really provide referrals and screening as early as possible. We want to increase the availability of support for persons with ADRD and their caregivers through memory cafes. And finally, we want to increase support and decrease the burden for caregivers through the workplace programs. So we are very fortunate to work with some fantastic community partners. One of them is Casa de la Luz. And I am thrilled to work with them on the agitation kits. When I first learned about this, I was just so impressed by the program and really excited for the work that it can do. So I'm not going to go into all of our partners, but we really, when we applied for the grant, we wanted it to be a community outreach. We wanted the whole community to be involved in it. And so we're very grateful to have all of these community partners working on different facets of the grant. All right, so diving into the grant itself. So one of the main ones is increasing outreach and awareness. We have created a dementia action team under United Way's Elder Alliance. We will be adopting a dementia-friendly community plan. And the goal of that is to create an environment so those living with dementia and their caregivers can go out into the community, and people they interact with have a base knowledge of dementia so that they can help support them. And that's where the Dementia Friends training piece comes in. We will also be offering Visibility Matters training, which is our LGBTQ module, which we're going to modify for the dementia population. And we're also doing a multimedia public awareness campaign. Like I said earlier, one of the things that we realized was extremely crucial was the identification and referral for people with ADRD and their caregivers. So our goal is to screen as many individuals living alone and persons with IDD so that we can know who really does need help, and we can provide early interventions for those individuals. We're going to provide referrals for assessment and services for individuals living with ADRD along with their caregivers. I keep saying one of, because there's so many great things that we're going to be doing. We will be starting memory cafes in Pima County. And so for those of you that are not aware, a memory cafe, which is sometimes referred to as an Alzheimer's cafe, it's a social gathering for individuals living with memory loss and their care partners. It's not meant to be a support group, but it's really meant to provide a break from focusing on the disease and disability. So it's a lot of times you will see memory cafes that are musically themed, or they will have arts and crafts, or pre-COVID, they will have baking competitions. So there's just a lot of fun ways that you can bring a group of people together, support them and kind of take their mind off their worries for a little bit, provide the caregivers with support, and come up with different ways to do interaction. So the agitation kits will play a crucial role in our memory cafes. And the final piece that we have is the workplace support program for caregivers. So we recognize that a lot of caregivers are still working, and we will be partnering with several local organizations who will allow us to come in and provide support and training for caregivers. So we will come in, we will provide free training. We will be using the powerful tools for caregiver, along with additional community resources and tools to train these employees on different tips for, like you guys were talking about earlier, how to help combat agitation, how to help with fatigue, what are different supports that are available within the community. All right, that is it in a nutshell. So please feel free and reach out to me if you have any questions. Don't hesitate to contact PCOA. We have a lot of resources on our website, and our helpline staff are always happy to help.
All right, thank you, Harbhajan. I am so impressed with everything, and I can't wait to even learn more. So thank you so much.
Thank you
for that. So in conclusion, so as you can see, we do this presentation for caregivers that are in facilities or are caregivers or also family members. So our best advice to you is knowing who your loved one is and remembering who they are when they were younger and those things that were important to them. Bring back that value that they had. Developing a plan of care that is reflective for their individual needs. We had a patient who grew up on around ducks. I don't think it was a duck farm, but being able to reconnect her to those things that she found so much fun. And so our volunteer actually made her a duck book. And who knew there were like 20 pages worth of ducks, but being able to reconnect her to that moment in time that she found value and something that she loved. Find items that the patient or your loved one may respond to for comfort, relaxation, or engagement. And that's huge, like Dr. Powell has talked about. Sometimes if your loved one's in pain, just looking at seeing if a Tylenol will help on a routinely basis so they never get extreme pain, or relaxation, creating an environment that allows relaxation and truly engagement. I cannot express enough how much engagement is needed. And again, focusing on your respite and your ability to take care of yourself and how you can do that. Changing your perspective on care. So we struggle with this a lot in the healthcare community because sometimes it's not just throwing medicine at a cause that is the best thing. So really changing your perspective on care. Going back to what Dr. Powell said, a baby doll may not be a baby doll to your loved one. It may be a connection to raising children. It may be a source of comfort of holding a grandchild. So again, changing your perspective on care. No medications are safe and effective for management of unwanted behaviors. So as Dr. Powell had shared with us, there can be downsides to medications. Now we would like to press that there are times that medications are needed. So we would never ask you to take your loved one off all of their medications, but sometimes having your medications looked at by a provider, because we found where they're conflicting medications because a neurologist prescribes something and a primary care prescribes something. So sometimes just a review of medications and making sure the ones that are on board are valued. Targeting the underlying causes of the behavior in the most effective way to manage. Again, sometimes that could just be decreasing boredom or finding that value that they had. There are resources in the community, as Harbhajan pointed out, so please reach out. They're there, and that's their purpose. And most importantly, self-care. Being able to take care of yourself, reaching out for those respites. If you're part of a faith-based organization and they say, come let me sit with your loved one, take that opportunity. You're not a burden to them. They're asking because they want to help. And sometimes just going in the other room and taking a nap, or going to the Starbucks and getting a coffee and reading a book, or going to the park and watching the ducks. Self-care is so important. We cannot impress upon that enough. If you don't care for yourself, you're going to burn out caring for your loved one. Here's a bunch of resources because we wanted to bring back those days that you were in school. So these are the resources that we had tapped into as we built this program. And on here also, you will see, I think it's number 5. No, number.
Mine's not on here yet.
Oh, we haven't added ours yet. We apologize. So these are resources that we have used to help build those programs. And questions, I'm going to unshare again. I'm not sure if there's questions in the chat box.
There are some questions.
Oh, fantastic.
All right. You can sit back and relax and then answer them if you want to. And I think we should have a field trip to the duck farm that you mentioned. That sounds pretty amazing. One of the questions is, how is someone referred to the agitation consult team? Do you have to be on hospice to be referred to it?
So that's a great question. So we have a community-based palliative care program. So some of our patients on our agitation program are on our community-based palliative care program. And so if there's a symptom and your loved one is in where we need to look at more palliative care, such as quality of life versus curing, some of our patients on our agitation program are palliative care. So you can call Casa de la Luz and we can talk to you, or we can refer you back to PCOA to see what options that they have. But right now, the patients that we do these for are our patients either on our hospice program or on our community-based palliative care program.
And just for a little bit more clarity, our palliative care program is not necessarily synonymous with end-of-life care. Palliative care does not have to be a 6-month prognosis that you think of with hospice. Palliative care does not mean that you have to be off of aggressive treatment. You can still be admitted to the hospital. You can still be getting chemotherapy. You can still be on aggressive measures and be on palliative care. Our palliative care team at Casa de la Luz is really for patients that have a severe disease process, such as severe dementia with uncontrolled behaviors, that need additional support and resources. So it's very difficult sometimes to disconnect hospice and palliative care. Hospice is more for the end of life, last 6 months, you're foregoing aggressive interventions. Palliative care is the step before that. When you're not ready for palliative care, but you still have severe disease process with severe symptoms, and you're still looking for that extra support.
Right. But if you contact us, we are happy to refer you or give you some direction as well.
Great, thank you. There's so many comments in there about how much this has helped and how it's the first time they've seen something about helping patients that's not based on medication. So people are so grateful about that. And someone's asking if you can tell us what items are on the fabric on the end of the table.
On these?
Yes, I believe right there.
Here, we'll both hold them up.
So this has some keys, because tactile things. So keys, or sometimes you can go into the baby selection sections and get the teething rings or things that have something for them to touch and feel. Zippers, buttons. This has like crunchies. Crunchies is probably not the word for it, but it has something that it feels like crunchies, textures, Velcro, a pocket for them to put stuff in, like remotes or just Kleenex. My dad was a Kleenex hider, so he would have loved this because he would have had Kleenex in there all the time.
This one
Bonnie says they're beads. The crunchies are beads.
Thank you, Bonnie. Bonnie actually probably made this, so thank you, Bonnie.
yeah. Hey, by the way, Bonnie, I stole some things from your office. So these are beads as well. These are blocks. You know those things at the dentist office that your kids play with, and you can move the blocks around. My kids are 8 and 10, and they still play with those. That's basically what these are. So you can move them around, slide them back and forth. Just really anything that provides sound or texture. It's meant to be stimulating of the different senses. So you can put something for smell, something for texture, something for sound, something for feel, just anything you can do to stimulate the senses that may not be used in any other form or fashion.
Great question. Thank you.
There's another question that says, do you think that the word behaviors is one that puts blame on the person rather than the care providers who are missing the signs of unmet needs? And what other word might we use? So just your reflections on that idea.
That's a fantastic question. Yes. I say the word behaviors because people understand what that means, because we are often the people that project that assessment onto our loved ones. But that's one of the reasons I say, what are these behaviors in the beginning of the talk, and list out several of them that we see. I think it would be far more beneficial to list the actual behavior to a certain degree, instead of saying behaviors as a generalized term. So Mr. So-and-so is restless. Mr. So-and-so is showing signs of pain. Mr. So-and-so or Mrs. So-and-so, to not be gender specific, is having difficulty managing the volume. It's too loud for him. If you can pinpoint the specific behavior, then that's a much better way to approach it, especially with the individual and the family. But it's also very difficult to lump it together and find one word to use in that situation as a generalized term. The technical term is behaviors of, it's BSPD. The behavioral symptoms in psychological something of dementia. Of course, I'm blanking on it when you ask me specifically. But behaviors is the word used in the technical term, which is why we say that repeatedly. We just shorten it to that. But it's a great question, and I agree with you. It definitely projects onto the person instead of using a more specific way to communicate someone's needs.
Thank you. And I know that we're about out of time. I see Julie looking at me that way, but I got to ask this other question. So we've seen the toll that the pandemic has placed on the family caregiver, and already the stress level and the efforts that that we all do to care for our loved ones in different situations. But can you talk a little bit more, just briefly, about the benefits that these non-pharm interventions, things that we can try to care for our loved ones who might have dementia, the benefits to the caregiver as well in that process?
Sure. So one of my favorite stories we haven't talked about yet, because I don't have the toy with me, is actually a seek and find. I don't know if you've ever seen it. It's basically like a tube, a clear tube with beads and toys inside, little tiny toys, a penny, a safety pin, just random small things that are inside. And you turn it upside down, you shift it side to side, and you look for these things. Can you find the penny? Can you find the penny? That's what we say all the time, because no one can find the penny. So one of the beautiful stories that we have is a gentleman who was behavioral, who we gave this seek and find to. And he sat there and he searched and searched for it. And every time a caregiver walked by, he'd say, can you find the penny? And so the caregiver would stop and would take a second and would look for whatever it was and say, I'm sorry, I can't find it. But it would increase and improve this engagement and give them something to focus on as a conversation between the two of them when a real conversation was not possible. So for someone who has difficulty communicating, who has difficulty focusing on a conversation, who has difficulty outside the here and now, it may be easy to answer the question, are you cold? Yes. Are you in pain? No. Whatever. But having a conversation is hard. On the other hand, being able to simply, can you find the penny? And then you hand it off. It creates this engagement. It creates this relationship from the person with dementia and the caregiver providing care to improve that engagement in a way that's beyond simple communication. So there's definitely ways that it improves the relationship and it gives them something to focus on besides that. I don't understand what you want, which can be frustrating for both sides.
And I would like to, so David and I have this little spiel we like to do right now about caregiving and COVID. So all of us have lived in this world that we would have never anticipated. And so again, I want to go back to, as a loved one and a caregiver, taking care of yourself. So even prior to the pandemic, what did you find value for yourself that refueled your soul? For me, it's taking a walk without my 7-year-old. You know, taking that and listening to a book on tape that has no value except entertainment. So still taking those moments for yourself through the pandemic, whether it's caring for a loved one that has dementia or just living through a pandemic, finding value and still being able to recenter your soul is important. You would think that I'd be thinner with all the walks, but I'm not yet. But again, so going back to those things you find value in.
That's why we all have to go run around the duck farm together. So
Yeah.
we'll just keep doing that.
Meditation, that's a great one.
There we go. There we go. Thank you all so much. This has been absolutely amazing. It's really brought to light the important work of the Agitation Consult team, of PCOA, and also brings awareness that there are resources out there for us all. And we just need to talk a little bit more and become more aware and rely on each other. So thank you so much for this time together. And I'm going to turn it back over to Julie now.
Thanks so much. I just want to say, Piper and Becky, how proud we are to support the work of your team. This is really groundbreaking stuff that, seems, it's like one of those, everything that's brilliant. It's sort of like, duh, why haven't we been doing this all along, right? But you're putting in the work to prove that it's effective. And so it really is our honor to support the work that you're doing. And Harbhajan, I am so excited to see how, what PCOA can bring to our community in terms of other resources and amplifying work like this and passing on tips and ideas to family caregivers and other caregivers. So thank you all for the work you're doing in the arena specific to dementia, Alzheimer's and other types. I want to say, I know some of you have been on these, we've been doing this series since January. We have another session coming up in May, and it is going to be all about natural alternatives to traditional burial and cremation. We'll be joined by a guest from a group called Recompose, and they're based in Seattle. So we've had a lot of interest in past sessions about this. So we're bringing them to join us. And then we're going to have a little break over the summer, June, July, and August, but we'll be back in September with a session with Tunadito about grief, childhood grief and the different stages that children go through age-wise and then the stages of grief. So we hope you can join us. I'm wishing you health, happiness, and a fabulous night. Thanks for taking time to be with us. Good night, everybody.